This question is directed to Dr. Herman. Did you use other markers to measure neural inflammation? And if so, what are they? And if not, why'd you only measure TNF-alpha?
Yes, we did actually look at quite a few others, so I'm just giving one example here. We actually see a pretty robust reduction in multiple inflammatory markers. So we've started to look at a couple of different inflammatory models. We're actually looking at an EAE model as well, which again, it's an MS model, but it gives us some idea of inflammation beyond just what we've seen. So yeah, we've looked at a whole litany of them. In fact, if you want to see more, we have posters on our website. So rather than me trying to remember all of them, it'll probably be easier.
I noticed that two of the 4 programs actually are, let's say, more limited to ApoE4 homozygotes, both your Martin Tolar's program and your Europe's program. So, besides, of course, the age of onset, what's the kind of fundamental different biology that for instance, actually made you select a particular patient population compared to the more general Alzheimer's population?
So, again, as I said earlier, number one driver for Alzheimer's is age. We all get Alzheimer's if you look long enough, if you look at the Kaplan-Meier survivor curves. Number two is ApoE4 genotype. Close to 60, maybe 65% of patients with Alzheimer's disease will have ApoE4 genotype. It's what we call completely distinct biological phenotype. Again, the disease starts earlier. And your question, main question is why? So ApoE is a protein that carries lipids in the body and has 3 forms. 3, which is considered normal. About half of the people on the planet have it. E2 is very rare. And then E4 is present. Every 5th person in this room has at least one copy of ApoE4. What it does is actually impairs, it's a loss of function in clearance of amyloid. Again, another reason why we can talk about the biology of Alzheimer's, but the key genetics actually, which really drives us as drug developers to develop the treatments, points to amyloid as being a key culprit and actually therapeutically the only one that so far has shown efficacy. So you impair, just by impairing, so think about it, right? So you get Alzheimer's because you live too long, because your blood vessels become crummy and cannot clear up all the garbage from the brain, or because you don't clear amyloid sufficiently, or because you make too much amyloid at birth. These are the 3 ways you can get Alzheimer's, which are very well known. So again, that's the reason why we decided initially to go into ApoE4. We had no idea how profound the effect is on the misdiagnosis. Again, you go from without E4 genotype, it's almost 50% misdiagnosis. With 2 copies, it's almost 100% accurate. And the progression of the disease, it happens in much younger patients. It happens in the 50s and 60s. That means that you don't have comorbidities, you don't have all the other vascular dementia, vascular pathology, and so forth. So that's why it's our first target. Our drug would work in anybody with Alzheimer's, but then you have to actually do, imaging to actually make sure, PET imaging or some other forms, to make sure that you have actually the disease. Because once you move from the ApoE4 homozygotes, it's about 1 million patients between US and Europe, you will have tremendous burden of misdiagnosis. And if you don't have the Alzheimer's disease, the treatments that target the pathology will not work.
Well, the rationale was also to address more genetic forms. That was a number one issue on one hand. And on the second, as the focus was to address early stage Alzheimer's disease cases, or MCIs, which is even more heterogeneous in nature, not all of them will convert to Alzheimer's disease. You needed those that you had fairly good confidence that they're going to be converted. And that said, we are dealing with a metabolically active compound, leptin, and ApoE and leptin are both in the realm of metabolic pathways. We had a scientific which behind it too. However, if the underlying rationale was to identify those that will convert from MCI to AD, another genetic pre-screening methodology is not going to be looked at. As I mentioned, we are deal with a potential partnership with a genetics company, and we may be able to employ a SNP-based algorithm that will give you a risk score for patients to convert to Alzheimer's.
I'll add to issue one other point. So for those people who follow Alzheimer's, there are this incredibly mixed bag. Any Alzheimer's patient, even if you truly have Alzheimer's, there are a number of these proteins that are left behind if you cannot clear it, in addition to amyloid, that cause pathologies. But it was a very surprising finding for those, again, who follow the late pathology. So there's a pathology that looks exactly like Alzheimer's, happens a little bit later in life. It's completely not Alzheimer's. It's called by TDP43, another protein that gets accumulated and gives you exactly the same clinical presentation, right? So we will need to, and again, our inspiration for the precision medicine, that we pioneered at Alzion has been cancer, right? You don't treat cancer with silver bullet. It will never happen. The same thing will not happen for Alzheimer's. There will not going to be one drug that works for everybody, and be mixed pathologies. You will have to have multiple treatments, and that's really the only rational approach. But again, the biology and our understanding of that has only recently sort of came to the point where this has become crystal clear, and the failures actually helped us with it.
Other questions?
This question is for Dr. Tolar. Thank you very much for your presentation. One of the slides that you showed with respect to post-hoc analysis of the data that you provided, focusing on a certain range of MMSE scores as well as the population that we were discussing regarding the ApoE4. What we observe in that slide is that it's a fairly large study, but when we are focusing on that narrow population, the N numbers go down to low double digits. Do you think this will constitute a problem for you while you guys going forward with the phase 3 trials in terms of getting these populations enrolled in the trial? Or how does the demographics look like?
So there were a number of questions here. The first one is the range, right? So the only way we can de-risk drug development is having patient data. We have 2,000 patients, and you're absolutely correct. It allowed us to understand what is the population, what is the stage of the disease we need to use, what is the dose, and how you're actually going to administer it. And we worked quite a bit to make sure that actually we get the right dose in the brain, which was called PK/PD with sufficient coverage, which has been, by the way, one of the major problems for drug development in Alzheimer's. Right? So that's where the data set helped. The second question you're having, how are we going to find the patients? So there is about 1 million of them between US and Europe, so quite a few patients. The problem is that how you find the ApoE4 homozygotes in the sort of the dry stage and so forth. What helped us tremendously, the understanding of the ApoE4 role is now so broad. I mean, 23andMe will tell you what is ApoE4 genotype, and they have out of 5 million people, about 1.5 million that have ApoE4 genotype, right? So that's number one. Number two, it's part of the clinical workup. If you come, I was at Yale on faculty. If you come to me and have dementia, I will look at ApoE4 because prognostically it's so critical. As I showed you in our study, in a year and a half, we go from little forgetful to almost institutionalized, right? So that's the other health. So it's becoming part of the workup, but still, right? I mean, we're obviously, we have worked quite a bit with the sites and with the CROs to make sure that we can enroll. That's an issue. But again, the problem is that somebody has to break through these 20 years of failures. And unless we focus actually, again, very specific and targeted way, it's just not going to happen.
Thank you.
Thank you. Last question in the front.
You mentioned about the ApoE4, and I don't mean to tag onto it again, but my mother, my grandmother, and all of my aunts and uncles had Alzheimer's age 65 was their onset. I'm also a nurse here today to bring this information, which has been absolutely wonderful, back to my nurses at Independence Blue Cross. My question is, I did the 23andMe. My ApoE4 was negative, and I want to take the next step. I'm going to see a cognitive neurologist. For the people here today who are wondering if you have Alzheimer's, I just wanted to know, what would you tell your daughter or your wife who carries the genetic history that I have? What would be your next step? And I wasn't sure if the 23andMe was, and I think you did answer that, if it was, something that was recognized, it looks like it was FDA approved.
Again, there were a number of questions. So 23andMe got in trouble, but they have FDA approved tests. So what they tell you is correct. What I would tell anybody with a genotype, we don't have a treatment. We're, as you see about the efforts, again, first thing I would tell them, try to help somehow support us, right? Because again, guys, the biggest problem in Alzheimer's drug development that everybody gave up. The big pharmas who have tons of money, they make profit-based decisions, they will not invest. The public and private investors are profit-based, they will not invest. You don't realize, right? If you look at actually the investments, the bio, which we're here actually part of, published a report showing the investment in cancer and the investment in Alzheimer's. Now it's apart by orders of magnitude, right? That's the biggest problem. There's nobody left actually to support a lot of these ideas that we are hearing here. The only thing that works in Alzheimer's is diet and exercise. It works. Actually, one of our scientific advisors, we activate about that, Karolinska, ran a study called Figure Study. And any basically support for cardiovascular health, right? William Walsler, the founder of American medicine, said you are as healthy as your vessels. It still applies 150 years later. Anything you can do for your vascular health. If you get older, maybe you want to be on statins, maybe you want to manage your cholesterol. There's another interesting study recently published showing that high LDL is the risk factor. So diet, exercise, and vascular treatment, cardiovascular treatment. And I'm a neurologist.
Yeah, so I think that's a fantastic question, and it's a fantastic point. We don't talk about prevention so much, right? And I think that one day we will talk more so than we do now for prevention of Alzheimer's disease, just like we are for cardiovascular disease and just like we are for cancer. The cardiovascular is a huge piece of it. Those things are all good for your brain health. Sleeping, also critical for your brain health. Being active, right? So there are lots of studies about things like ballroom dancing and challenging yourself to do new things. I think these are the types of things that, as you said, what do you tell your friends and family? Those are the things we tell them. I think that the key that we're talking about here today is really how to bridge that gap so that we can have the cholesterol test or LDL test that has helped our cardiovascular colleagues to say, here's your risk stratification along with your genetics, and we should have precision targeted treatments, early stage, late stage, symptomatic treatments so that we can have really robust treatments.
I'll just add to it, actually, the sleep is incredibly important. We learned, when we went through medical school, we were told there's no drainage from the brain, and we understand how critical it is. Because you, again, have to clear 3 pounds of garbage every year. The only time when you do that is when you sleep.
Well,
so it's actually shown that actually people who have disturbance in sleep actually tend to actually end up doing Alzheimer's. It's sort of a conversion to that. The other thing I'm going to say, what we're looking for, and we need to actually get to the point where we're treating Alzheimer's like cardiovascular diseases. You have patients at a certain age, you look at their family history and their genotype, their biomarkers. Again, in cardiovascular is the cholesterol, in Alzheimer's is going to be the amyloid and whatever else, and then you prevent. Because we have 15, 20 years from the initial damage to the brain until you get the symptoms.
Well, can I refine the suggestion?
okay.
Measurement of leptin is going to help you improve both your exercise and blood pressure.
Okay, actually, in the forward-thinking mode of Investor Cure, there's a session, there's a talk that will address your specific question, which is, okay, here are the parameters. What can I do to minimize or prevent developing AD? So that's coming up.
I'd like to thank all the panelists and the moderator for this session. We're going to take a break.